In the interest of everyone's time, I'll start. Thank you all for joining. Good evening, ladies and gentlemen. We welcome you to the national webinar on taking diabetes to heart, which is a unique initiative and brings together a clinician and a lab. What better way to celebrate World Diabetes Month than to listen to two stalwarts from their respective industries highlight the important link between diabetes and heart? I am Dr. Sai, Marketing Lead for Cardiology, and I have Dr. Bhushan with me, my medical counterpart. Together, we welcome you on behalf of Roche Diagnostics India. We have with us today Dr. Amay Joshi, a leading endocrinologist from Mumbai and a pioneer in his work on T2D management and especially the occult heart failure link. We also have Dr. Preet Kaur, a KOL in pathology and currently Vice President, Lab Operations and Quality at Thyrocare. I'm sure it is going to be a delight to our ears to listen to both of them highlighting the patient journey of a diabetic right from diagnosis, management, and what exactly happens at the heart level. Without further ado, I invite Dr. Amay Joshi to start with his presentation on clinical utility of NT-proBNP risk assessment tool for CVD in T2DM cases.
Good evening, ladies and gentlemen. At the outset, let me express my gratitude to all of you for joining today evening for this webinar on clinical utility of NT-proBNP biomarker as a risk assessment tool for cardiovascular disease in type 2 diabetes mellitus. I am Dr. Ameya Joshi, consultant in charge of endocrinology at Bhaktivedanta Hospital and Research Institute. And the unique thing that I will be discussing is the real world experience of using NT-proBNP in outpatient department. So whenever we see a person with diabetes and then if the person has came to the OPD, let us think what we will do to assure him about his cardiac status, because the person will definitely have this query. Will we verbally ask him, okay, these symptoms are there, not there? If not there, okay, you are fine. Will we get a ECG and tell, okay, everything is all right? Will we get a ASCVD risk score? Or as we do a creatinine, urine microalbumin, SGOT, SGPT, we will get some biomarker for cardiac health. And I think all these are good and true, as Swami Vivekananda ji said, Ruchinam Vaichitriat Ruchukutilana Pathajusham, Drunameko Gamyas Tamasi Payasamaranam. We will all do things as per best of our knowledge, as per the best of our capacity and the patient's affordability, and do the best to proactively pick up any complication, for that matter, not even heart disease, in a person who has came to consult. Cardiovascular diseases are the leading cause of mortality amongst diabetics, and an cardiovascular event permanently deteriorates the life of patient if both quantitatively and qualitatively. We have been thinking of cardiovascular disease as a equivalent to coronary artery disease, but we must also remember that heart failure is an underappreciated complication of type 2 diabetes mellitus, with prevalence data claiming 22% people with diabetes mellitus could be having an underlying heart failure. And over a period of time, recommendations have evolved endorsing various screening methodologies, but what is recommended now is the use of a biomarker, and the most validated biomarker is NT-proBNP, first endorsed in 2022 by an ADA position paper and then confirmed by ADA guidelines in 2024 January. As a person with diabetes lives with diabetes, the risk of heart failure progressively increases, and it is much more in diabetics as compared to non-diabetics. So in whom should we look for heart failure? And obviously, the obvious answer will be anyone who says that they have symptoms, or anyone who comes to the emergency room seeking care with symptoms. But is it a time to go beyond that and pick up occult heart failure in an asymptomatic patient in an outpatient department? And the question is, why will you do it? So let us begin with a type 2 diabetic patient coming to the OPD who never had a cardiac event. and you know is asymptomatic, will you screen for heart failure? And my answer is why not? Because that gives you an idea about which regimen to choose, like SGLT2 inhibitors, GLP-1 receptor agonist, how to discuss with the patient. Does that patient need a mineralocorticoid antagonist or additional therapy like sacuval? Does the patient need a reference to a cardiologist for proactive screening for ischemic heart disease and to medically optimize the management not only of ischemia but even hypertension and obesity, which can reduce the chances of hospitalization? And the guidelines actually tell you that if the person has heart failure, consider SGL2 inhibitor first line, GLP-1 as a possible addendum. So you cannot even go on prescribing the medication without screening for heart failure. And the objective simple way to do is to look for NT-proBNP blood test. And the algorithm proceeds only after that. So what was being done till now? And what we were doing was an ASCVD risk score. At least we were saying we are doing. Most of the times it used to be a verbal screening and ECG. But let me tell you that ASCVD risk score is for Americans, not validated for Indians, even rejected by Europeans. And it underestimates the risk in vulnerable population and low socioeconomic groups. More importantly, what we realized is that those with a family history of heart disease also have this problem of underestimation, and then non-traditional risk factors are there. And it might overestimate the risk in higher socioeconomic groups and those on regular follow. So we tried to look at people who landed up with ASCVD. A proportion of them we classified all of them as those who had an event. And then we looked at the EMR and got people who were age and sex matched and did not have an event. And did we back tested the ASCVD risk score, and we realized that the ASCVD risk score was not different in people who had an event and who did not have an event. And the risk estimated by ASCVD risk score was much lower as compared to the actual risk. The population risk that we got was 16% in 6 years, and the actual risk was 14.5% in 10 years. The ASCVD risk engine predicted almost similar risk in cases and control, and heredity, which was an important risk factor, was actually missed in the ASCVD risk score. The advanced risk engine model, which again we presented in Berlin, has Indian data and was little more closer to the numbers that we got. And this is that data. And then we come to the routine practices again, with which recommendation which we were studying. And we do an ECG and 2D echo. But the ECG has a yield as low as 4%. And 2D echo is highly operator dependent. And it is not unusual to get a normal report, whereas fine analysis can actually point towards heart failure. So we tried to look at some papers, and we came across this paper in Circulation, published in 2016, at markers that predicted the cardiac events. And we zeroed down on two markers, one structural, that is coronary calcium score, and one functional, that is NT-proBNP. NT-proBNP, the advantage is there is no radiation exposure. It is much more economical, no separate appointment, go to the lab, get it done, or it's available in the ER, and much less expensive. Whereas coronary calcium scoring is radiological and it is much more expensive. Also to tell you that not all failure in diabetics is ischemic, whereas NT-proBNP picks up ischemic and non-ischemic risk, whereas coronary calcium score is ischemia specific. What is exactly this NT-proBNP? It is a biologically inactive 76 amino terminal fragment which has better sensitivity for heart failure diagnosis, better predictive value, and does not cross-react with BNP and has a longer half-life. So becomes more sensitive, whereas BNP has a shorter half-life, less better predictive value, more cross-reactivity. BNP is an active fragment. use of NT-proBNP cutoff of 125 is a strong predictor of hospitalization in type 2 diabetics with or without established heart failure. And across the guidelines, it has been recommended. The Japanese were the most proactive to recommend in 2021, ADA in 2022, and ESC in 2019 recommended use of NT-proBNP as a screening marker for cardiac health in type 2 diabetes. And we started implementing this in our population, and then we thought of analyzing after 1 year of implementing this in our population that all outpatient diabetic patients were offered to get an NT-proBNP screening. Whichever person did it, we analyzed the data and then we published this in this curious journal, and I will be sharing that study with you. That is a real world evidence from our own Indian population. So the aim was to identify the prevalence of occult heart failure among type 2 diabetic subjects with normal ECG by using NT-proBNP. We also thought that, okay, this marker can be expensive for our patients. So we will try to see whether we can identify those who are at highest risk. So we decided on picking up people over a period of time, and the minimum sample needed was 264, but our study had 1049 patients. So it's a very robust study actually. All type 2 diabetics attending the outpatient department of a tertiary care institute with a normal resting ECG were included, excluding those with pregnancy, arrhythmias, prior heart failure, chronic kidney disease, chronic liver disease, known CAD, respiratory failure, malignancy, or terminal illness. So those who screened positive for heart failure with an NT-proBNP more than 125, we noted their demographics, their duration of diabetes, their body mass index, blood pressure, heart rate, HbA1c, lipid profile, renal and liver function test. And those who screened positive were referred to a cardiologist for further workup, and we will be discussing that. But to our surprise, 1/3 of our patients, 32%, had NT-proBNP level above 125 nanogram per ml, confirming that they had screened positive for heart failure. Now, which were the factors that increase the risk of heart failure? Duration of diabetes increased the risk of heart failure. Smoking increased the risk of heart failure. Tobacco chewing increased the risk of heart failure remarkably. So attention, viewers, please make sure that all your diabetic patients chewing tobacco are at high risk for heart failure. Those who were hypertensive had higher risk. Those who needed more BP medications, those who had higher blood pressures were at high risk for heart failure. Raised pulse rate was a risk factor for heart failure. Elevated LDL levels, elevated BMI, elevated glycated hemoglobin, positive family history, and presence of a chronic kidney disease. Again, we excluded those with eGFR below 30, but albuminuria was a risk factor for heart failure. With each year increase in the age, the odds of having heart failure increased by 9%. Smokers, those with positive family history, individuals with CKD, and those with raised blood pressure tend to be at higher risk for heart failure. We also published or presented a study in EASD about a subset where hypertensive with diabetic population was screened, and we identified that 38% of this subset actually have heart failure. Now, this was before 2024 that this data was generated, and in 2024 the ADA standard of care recommended that consider screening adults with diabetes by measuring natriuretic peptide BNP or NT-proBNP to facilitate prevention of heart failure. They call this stage B detection, where therapeutic intervention is most useful, and they endorsed NT-proBNP over BNP. So NT-proBNP is a simple blood test. Any level above 125 increases risk of heart failure. Send them to a cardiologist for more workup, and guideline directed treatment is needed. Now you will ask me, all my patients are on SGLT2 inhibitors, doctor. I control BP of everyone well. Why do you want me to use this marker? So one is treatment change, but another is, will you do a stress test, or for that matter, coronary calcium screening of your patient? That will be told to you again by this. any medication change for hypertension do you need will also be told by this. So let us look at the atherosclerosis screening, and then again we have been doing carotid and ankle brachial index, but what is more useful is a coronary calcium score, which actually correlates much better with ischemia and the heart rather than any other peripheral marker. And in our study, out of 336, 247 underwent coronary calcium scoring, and a good number, close to 70% of them had actually ischemia evidence as documented by coronary calcium scoring, and all underwent major treatment changes. Some of them underwent angioplasty, some were optimized by medical management, but all of them did better. So once you screen positive, definitely refer to a cardiologist who will screen for ischemia, intensify statins, add antiplatelets, start rehabilitation. But you also, as a diabetologist and endocrinologist, will do a treatment change, screen for secondary hypertension. We found a good number had low renin hypertension, and treating their low renins with a mineralocorticoid antagonist helped us. OSA screening can help. Obesity treatments can help you prevent heart failure, and then dietary changes. Also, not all coronary calcium scores above 100 are significant, and NT-proBNP helped us identify which are significant, because sometimes there is age related calcification in patients on statin particularly. But if you have a calcification with raised NT-proBNP, there is a room to consider coronary angiography. Now let us move out to the management perspectives of diabetes, and here I can tell you the same picture that I showed you before, that your diabetes treatment algorithm clearly states that screen for heart failure before you prescribe treatment, identify kisko heart failure had, then give a treatment accordingly. Your hypertension treatment changes, your heart rate becomes a significant parameter to monitor. Renin level, we do it in all people with raised NT-proBNP to identify low renin hypertension. Primary hyperaldosteronism is an unrecognized cause which is missed. This is from the ADA position paper. And if you don't remember everything, at least remember this checklist. I have tried to look at all the heart failure data and compile this. NT-proBNP above 125, increase hemoglobin above 11, keep HbA1c below 7.5, keep BMI below 25, heart rate below 70, blood pressure well controlled, LDL below 70, thyro normalcy. Many people have subclinical toxicosis. Even hypothyroid patients are overtreated and they land up with this. Reduce albuminuria, look at coronary stenosis, and measure renin levels and try to normalize renin levels. Now we will move on to the case discussion part of it, because I thought after taking the theory part, I should take some clinical case discussions. So a 57-year-old gentleman came to the emergency department with neck pain radiating to the left arm. He's diabetic since 10 years, hypertensive since 8 years. His HbA1c is 7.2. He's on metformin, sitagliptin, dapagliflozin, rosuvastatin, telmisartan. His ECG was normal and a tropi was done, which was negative. Cardiologist said it's unstable angina. Let me do an angiography. Patient said no. We were worried to send the patient home. We did an NT-proBNP. It came 20. To doubly sure, we did a coronary calcium scoring. Patient ko bola non-invasive, get it done. He got it done immediately. Report came in 5 minutes. Patient said no blockage in the heart. I'm going home. He was given symptomatic treatment. Otherwise, even if the patient would have received and have refused angiography, he would have been given maybe heparin, admitted to ICU, antiplatelet, statin, nitrates, etc., would have been given. So it is also important to have a negative screening, because you will have people who will say, okay, doctor, I am getting genital fungal infection. So what to do? Screen NT-proBNP. If your NT-proBNP is normal, you can even tell them that, okay, SGLT2 inhibitors are important, but we can look at other therapies, and at least you know that you are not harming the patient. The second case is a 57-year-old gentleman, diabetic since 12 years, hypertensive since 15 years. On inquiry, coming with dyspnea on exertion, occasional chest discomfort, was due for knee joint surgery. ECG was normal, echo was normal. So we did an NT-proBNP, which was elevated. Coronary calcium scoring was 980. So the patient actually did not undergo a knee joint surgery, but we asked the patient to undergo coronary intervention. He was diagnosed with multivessel disease, underwent a CABG. Imagine if we not have done, he would have landed up with probably a event on table. So the practical way is do NT-proBNP annually, raised above 125. If the patient agrees, screen for ischemia. If not, at least do 2D echo, give guided therapy, consider SGLT2 inhibitors, GLP-1 RA, Pinrenon or MRA, sacubitril valsartan, and give a patient a better quality of life. The third patient is a 60-year-old lady presented to OPD, diabetic since 15 years, hypertensive. NT-proBNP routine screening was done, was raised. The coronary calcium scoring showed a LAD dominant disease. The next step was coronary angiography, but the patient refused for same. But the literature actually says that it is important to diagnose ischemia, to treat ischemia. If you do not do an intervention, at least give best medical management, and that can give comparable result to an intervention. And that was seen in this ischemia trial of 2019. So what is important is diagnosis. What is important is care, so that we can give the patient best treatment. So to conclude, heart failure remains an under-recognized complication of type 2 diabetes. It may be significantly prevalent even with a normal ECG and 2D echo. Chances increase with increasing age, longer duration of diabetes, positive family history, smoking, presence of CKD and uncontrolled hypertension. Occult ischemia can be an important contributory factor to heart failure, and recognition of heart failure is important. And the best way, the recommended way to do it is by checking for NT-proBNP. I thank all my team at Bhaktivedanta Hospital who helped me do this study. It was a team effort, and we are presenting this Indian data so that you can do NT-proBNP screening, if not universally, at least in the most deserved population. Thank you one and all for your patient listening.
Thank you, Dr. Amay. It was indeed a brilliant session in terms of understanding how do we pick up the asymptomatic heart failure in OPD, deciding the comprehensive algorithm and a simple checklist. We now move on to the next presentation for today. We have Dr. Preet with us, who will take a lab perspective and explain how and what role the lab plays in the patient pathway. Over to you, ma'am. Let me share the screen.
Good evening, everyone. After the lucid talk given by Dr. Amaya Joshi on the clinical utility of the biomarkers anti-proBNP in the type 2 DM patients, I would now like to bring to you what exactly is the role of lab in bringing this cardiac parameter in the entire gamut of the journey of a patient of type 2 DM. Yeah, next please. So just Sai, if you can just move. Yeah, thanks. So just a small brief about me. I'm a medical pathologist with more than 16 years of experience in lab reporting and lab operations. And currently I'm heading the Thyrocare labs. Next, please. Yeah, this is just the disclaimer slide. Okay, so the agenda, I would be taking you through a small introduction of about what we do, what our organization does. And then we have done quite an extensive study on the HbA1c epidemiology study for the diabetes and the pre-diabetes patients. Then the topic for today, the type 2 diabetes patients and the utility of anti-proBNP exactly in the heart failure in these patients. And then coming to it, what is the role of lab? Where exactly does the lab help the clinicians to make an informed decision? What are the various benefits? And finally, what is the take-home message? Yeah. So just a small introduction. Next, please. For what do we do? Thyrocare, as we all know, is one of the pioneers in the diagnostics lab chain. So we do almost more than 70,000 samples per day. And around 3 years back, when pharmacy took over Thyrocare, we have constantly implemented a lot of initiatives in quality and on the accreditation front to constantly raise the bar and be the forefront, both in terms of quality and accreditation. Next, please. So we are a strong lab chain with 30 labs across the country, both in Tier 1 and Tier 2 and Tier 3 cities as well. We have 2 reference laboratories, one in Mumbai and one in Gurgaon. Both of these do multitude of tests, not only the basic test. In addition to the basic test, we do a whole lot of specialized testing. And our report stat is one of the quickest in the industry. So almost more than 98% of our tests get released within 6 hours of the sample reaching the lab. And 6 hours, when I say, it is for the P95 or for the 100% of test, but our average stat would be around 2 to 2.5 hours. And we have a huge capacity of processing samples, almost more than 1 lakh samples. Please go ahead. And on the quality front, as I already mentioned, in the pre-pharmacy era, we had just 1 or 2 laboratories which were enable accredited. But today, being the torch bearer of quality, we have 28 labs. So this is an old slide, but the updated number is 28 labs out of 30 labs are enable accredited. And the rest 2 labs are awaiting the certification. The audits have been completed. We are also the bearer of the CAP accreditation, which is the highest accreditation body in pathology, which is the College of American Pathologists. And all of our labs are also ISO certified. So a whole lot of investment and a whole lot of effort goes into bringing the quality to the highest standards while processing the samples. Next, please. And we have a huge fleet of doctors. The updated number is around 78 doctors. All of these doctors are MD pathologists, MD microbiologists, and MD biochemists. So roughly about 1.5 to 2 full-timer doctors. Each lab is the ratio which we follow. Next, please. And all of our doctors, they release all the reports after a huge verification and clinical correlation at their end in the labs. After implementing a whole lot of quality processes, we did a third-party doctor survey, and this was done by a third party. And the clinicians included in the survey were from various specialties, be it physicians, diabetologists, endocrinologists, cardiologists, and all of them. And we found out that 9 out of 10 doctors, they recommended our reports, and they found our reports and results highly accurate and reliable. Next, please. Coming to the next, so the diabetes study at Thyrocare. Next, so Thyrocare Anusandhan is basically the Thyrocare research wing, which we have recently introduced. So under this wing, what we do is Thyrocare is one of the bulk processors or lab of sample processing. What we do is we take a whole lot of data and we put it to a lot of data analysis and clinical correlation. And whatever are the deductions, like Dr. Amaya also showed a lot of research, articles being done. What we do is we do a whole lot of research on all of these parameters and clinically correlate with the other parameters. And whatever are the deductions, we release them as either publications or webinars or clinical awareness tools, helping our clinicians to take well-informed decisions. So not only are the clinicians, helped by, by all of these trends, whatever demographic changes or whatever, either trends or whatever can be seen by these studies, but they also help to improvise patient outcomes. So one such study is about the HbA1cs. In the last year, 2023, we approximately analyzed 19,70,000 samples, which were processed in for HbA1c. All these HbA1c samples were processed as a part of a preventive health checkup. So majorly, these patients were either asymptomatic, or probably they were just on the brink of getting diabetes, or probably they were just pre-symptomatic, right? And what we found out was significant deductions. We found out that the numbers generally mentioned as diabetes are usually lower than compared to the actual ground reality. So about 22% of the population, they tested positive as pre-diabetic. This is an HbA1c 5.7 to 6.4. And roughly about 27% of the patients were labeled as diabetes with an HbA1c of more than 6.5%. Higher female population showed pre-diabetic condition when compared to male population who showed a proper labeled diabetes in this screening packages. All of the age groups generally show a higher number of diabetes than pre-diabetes, except for the age group 18 to 35 years. So when I say that, that means there is a huge work to be done in this age group when exactly the individuals probably do not pay so much of attention to health. But 18 to 35 is the age group when the pre-diabetic occurrence is more compared to diabetes. And the highest proportion of both pre and diabetics are in the 51 to 65 years age group. Next, please. So this is also a countrywide presentation. This map shows the countrywide prevalence of pre-diabetes and diabetes in our country. So if you look at the states in the eastern part of the country, they have a higher prevalence of both pre-diabetes and diabetes. Orissa being the notable state with a very high prevalence, and it goes on reducing, next please, to the states where the consumption of wheat is more. So all those states where the consumption of rice is more showed a higher burden of pre-diabetes and diabetes. Next, please. So these are the summary of the deductions of this study. We found out that the number of estimated diabetics is much, much higher when compared to other studies. Probably we are only looking at the tip of the iceberg. There is a lot of groundwork to be done. The gender specific, and we just mentioned about the females having higher pre-diabetes when compared to males. And yes, there is a definite correlation, dietary correlation of type 2 DM with rice when compared to the correlation with wheat. Next, please. Coming to the today's topic. Yeah, next, please. So, what is the need to screen for heart failure? Dr. Amaya mentioned it very lucidly and very explicitly. He clearly pointed out that heart failure is the next common complication in type 2 diabetes mellitus. All our clinician friends should look for it, even if there are symptoms or there are not symptoms in the patients of type 2 DM. So what we did is we've done a lot of research and review of literature, and we found out that approximately up to 46% of patients of type 2 diabetes mellitus will develop some form of a CVD. Most likely it is going to be a heart failure in their lifetime. And heart failure amongst all the CVD in type 2 diabetes mellitus is the earliest, most common, and a very serious CV complication in diabetes. Having said this, not only that, the occurrence or the increased risk of death events in patients with heart failure in type 2 diabetes mellitus, it increases by almost 4 to 8 times when compared to patients of type 2 diabetes mellitus without heart failure. So that is the quantum we are talking about. So there is such a high risk, there it is such a serious complication. Having said that, it is still easily diagnosable and easily manageable condition. So if we are able to do an early intervention, the clinicians along with the patients can improvise the quality of a type 2 DM patient, and not only that, can also reduce morbidity and mortality. Now, while we are very clear that we have to screen heart failure, what should be the ideal tool to screen for HF? Like in the previous presentation, Dr. Amaya showed a clear-cut comparison between the NT-proBNP and the calcium, coronary calcium, right? One of them is an invasive and non-invasive. Not going to repeat all of that, but anti-proBNP seems to be the ideal screen or ideal tool for a screening of patients for heart failure in type 2 DM. What does European Society of Cardiology says? It says that a systemic survey for heart failure symptoms and or signs, either laboratory directed or non-lab directed, needs to be done, and it is recommended at each clinical encounter or visit of patients with diabetes type 2. So the moment an anti-pro-BNP raises above 125, okay, so that means it is an elevated. Suppose if it is normal, we just repeat it in 1 year, right? After every 1 year, we repeat it and we push the patient to stage A, where he still is a factor or still vulnerable to developing HF. Now, this patient stage A can move to a cardiac dysfunction or abnormality in due course of time. But the moment an anti-proBNP becomes elevated more than 125, the patient definitely needs to go to the second set or second battery of invasive investigations. Now that can be anything, echocardiogram, chest x-ray, can be also calcium, coronary calcium, anything. But we cannot ignore an anti-proBNP which has come positive, because we are just delaying the diagnosis of heart failure, because that is going to anyways occur at one or the other point in that particular patient. Next, please. Now, while I have tried to explain you how critical is this parameter for screening of HF in the DM patients, how does lab help here? Next, please. So lab is a very important role, and we take pride in that. Whenever there is a patient, whether symptomatic or asymptomatic. A symptomatic patient will generally have, will go to the doctor, a specialist, or an endocrinologist, or a diabetologist, and the particular clinician would give him a battery of investigations like blood glucose, HbA1c, and all that. And sometimes people who are well aware, they would also screen themselves. So they also have a battery of health checkups done, right? In either of these cases, the lab's role starts right here. Okay, so once these investigations are given to the laboratory, the battery of reports are received by the clinician. Now the reports will help the clinician to divide these patients either into pre-diabetes or into type 2 diabetes, developed patients, right? Pre-diabetes patients will definitely, the clinician would actually advise, some lifestyle management, some physical exercise, some cutting down of the sugar or carbohydrates, dietary changes and all that. But for a type 2 diabetes patient, not only these lifestyle changes, along with these lifestyle changes, important is to start pharmacotherapy. But now at this point, the clinicians need to know, which most of the clinicians do it, but it is important that the clinician also takes help of the lab and screen these patients for the complications associated with diabetes. And the foremost is the CVD risk factor, right? A simple so generally what we do is we would do a whole lot of other tests like lipid and all those. But an anti-proBNP as a baseline investigation is advised and is recommended over there. And of course, if it is elevated, we already discussed, we would have to go to the next set of investigations. Next, please. Not only this, in addition to diagnosing, identifying, monitoring, creating baseline investigation, and also helping manage these investigations. That's precisely is the role of the lab all throughout the patient's life in type 2 diabetes mellitus. Next, please. Now, what are the benefits of using an anti-proBNP in this setting? So what we generally do is laboratory testing for diabetes packages. Now these could be at three levels, three sections, three cards or three levels. So there are the elemental test. So we say IHE or the elemental test to begin with. A whole lot of elemental tests like CBC, fasting glucose, PP glucose, urine glucose. All these tests, not only the clinicians would advise, sometimes the patient out of their own awareness and, listening hearsay or maybe packages, they would pick up all of this. These tests will only help to screen, maybe diagnose, or maybe give you some baseline investigations, but they are not going to help into the further. I mean, they would help managing the further management, but for complications, no. They do not help it over there. They drop over there itself. Their purpose gets served, and they would help in the other areas, but not in the management of complications. Next is the holistic approach. In addition to this, the clinicians would add up other tests like HbA1c, KFT, lipid, microalbumin, fructosamide. These all will help the clinician to take informed decisions whether the patient needs to be purely put on a lifestyle, intervention, or the patient needs pharmacotherapy, or if there is a complication, whether I need to take care of that, monitoring and all that. And finally is the integrated approach. Integrated approach is the one which is being pursued by many clinicians across the globe, wherein the clinician will also screen the patients for the complication. And the most common is the cardiovascular and nephropathy, right? And for cardiovascular, precisely anti-proBNP is that one single biomarker which helps to pick up and identify HF patients and type 2 DM patients. So this is how ideally elemental, holistic and an integrated approach which should ideally be taken to manage the patients well. Next, please. And these are all the other common cardiac risk markers. So there are a huge number of them like lipoprotein, HDL, LDL, lipids, apolipoproteins. But if you look at them, none of them is specific in a manner how anti-proBNP functions, and they have their own limitations. So these can be lifestyle influences, dependent on fasting status, depending upon the demographics. These all would be non-specific, and they may only point towards a tentative diagnosis, but they will not specifically place the finger on it that, oh, you are looking at a CVD complicated case. So that's the need. That's the reason we need all the more an anti-proBNP to help us to diagnose and manage an HF patient. Next, please. What are the benefits of using this anti-proBNP? The benefits are huge. Like we said, if we are able to diagnose and early pick up these HF patients, this will reduce the morbidity, mortality, and the patient outcome is much, much better Like we saw that a patient with a whole lot of comorbidities will definitely fare bad or worse when compared to a patient with an only type 2 DM to be managed. It also reduces the burden on the other healthcare resources. For example, if we have a patient who has already gone into a full blown HF rather than a patient who has just started with an HF, the management is much simpler, easier, and as compared to the patient who has already developed some complications and angioplasties, angiographies, echo, and everything, that burden increases. We have a clear cut objective cutoff, which helps the clinician to confidently take decisions, well informed decisions. And now, like the world is all about doing an evidence based practice. So for a clinician, this kind of a biomarker or this kind of a report or support from the lab helps him or her to take a confident clinical decision making as well. And not only that, from the lab perspective, of course, our role in the entire gamut or of the cardiac care for type 2 diabetes mellitus has escalated or has elevated. Otherwise, what would have happened is, for standalone labs, we are generally the managers, or we're generally helpful in the management of their preliminary diagnosis of diabetes, maybe the day-to-day monitoring and all that. But once the complication sets in, the patient moves to the hospital-based labs and moves to the more of wellness, or where there is a more of a clinician touch-based practice. But now with this kind of a biomarker, the standalone laboratories have a bigger role to play in the patients with type 2 DM, and also because the reach of these labs is very high. For a hospital-based lab, it is not possible to go to even tier 3, tier 4. But for a lab like Thyrocare and bigger lab chains, the reach of processing these samples and giving this parameter to tier 3 and tier 4 cities is much, much higher. The accessibility, the reach is much higher, and because of this, the patient benefits in a higher, in a better manner. So that's about how the lab's testing volumes can be increased and the HF risk can be easily picked up. Next, please. Next, please. Okay, there could be some of these interfering factors. For example, age. Anti-proBNP can actually increase with age, but we have to rule out those comorbidities to rule out those age-related. Like, for example, even renal failure. Renal failure patients can also have an elevated anti-proBNP because of a reduced clearance, but there would be a definite indication in the RFT parameters that the patient also has a comorbidity, like a reduced renal function or a CKD or something. And clinical correlation is the key. So whenever a clinician is facing a patient with an anti-proBNP, of course, I'm sure most of our clinician partners and clinician friends would also be doing a complete holistic clinical correlation, only considering the anti-proBNP in a toto. So a clinical correlation is the important key factor while evaluating or while looking at the anti-proBNP values. So other antibodies, they show minimal or nil interference in these assays. Pre-analytical errors, a thorough screening needs to be done at the lab end to rule out any pre-analytical values. A proper discussion or a dialogue with the clinician. So, for example, if one of the patient sample is like anti-proBNP more than 800 or 700 or 1300, a proper dialogue or a critical call alert to the clinician needs to be done from the lab to rule out any other false positive reasons. And strangely, of course, BMI, any obese patient or overweight patients, they may record slightly lower values of anti-proBNP. So in actuals, they have an anti-proBNP value which is really high, but since they are obese and they're overweight, their anti-proBNP values can be slightly reduced. Next, please. So these are the interfering factors and how to deal with them. And finally, I come to the next, please, to the take-home message. I would like to actually, corroborate the same kind of findings which Dr. Amaya said. It is one important biomarker which shows the heart failure risk very easily. It's a non-invasive test and it can be done in the home comfort of patients. It limits the burden of healthcare resources by reducing unnecessary invasive investigations, gives a higher quality of life to the patients and reduces morbidities, mortality. Highly specific, highly sensitive. And like we said, prevention is much, much better than cure. Next, please. So picking up the patients at earlier stage is much better than, I try to solve or repair or trying to, do invasive interventions or investigations at a later date. So by this, I end my talk, and I would like to thank the Roche team and Tamaya and all my colleagues on this forum. Thanks for the patient hearing. Thank you.
Yeah, thank you so much, Dr. Joshi and Dr. Preet Kaur, for your insightful presentations. I'm sure that the audience would agree with me. Now we proceed with the question and answer session of our agenda. Just as a fact, we have received more than 130 questions during the course of your presentations. And because of the time limitations, we simply cannot cover all of the questions, obviously. So what I have done in the meantime is that I have bucketed the similar nature kind of question and would be asking the questions on behalf of audience to each and every speaker here. So let me start with asking few initial questions to Dr. Joshi. So, sir, I mean, the audience basically started actually, they wanted to understand what exactly makes heart weak in type 2 diabetes mellitus patient. What would be the underlying pathology that you would like to tell the audience?
Yeah, I would like to tell the audience that the heart in diabetes, the mindset was coronary artery disease. But with this NT-proBNP screening, we realized that there are three factors that can weaken the heart. And one of them is coronary artery disease. That is a macrovascular disease, which was seen in 70% of the people. But 30% had a zero coronary calcium score and still a heart failure. So what contributes in them is microvascular disease, which results in diabetic cardiomyopathy. Then that is the second aspect. And then the third aspect. Microvascular disease also includes advanced glycation end products and metabolic insult to the heart. So let us bucket that microvascular disease or metabolic insult to the heart. And the third is the overall body dynamics. Anemia being more common in diabetes, then obesity being more common in diabetes, uncontrolled hypertension being more common. So these are the post-cardiac factors which also contribute to making the heart weak. So roughly these three ways you can look at the heart getting weaker in diabetes.
Okay, thank you for your response, sir. So second question also I'll redirect to you. So this is a combined question, basically made up of multiple things. And just to let the audience know and the speakers know as well, we are above 500 count from the audience perspective. Some of them might have joined at the later stage of the presentation. So this particular question would benefit them. Like if a clinician wants to start prescribing anti-proBNP to his T2DM patients, sir, what would be your advice? First sub question is whether you would advise for all the T2DM patients who are walking into your OPD, or would you select only high risk cases whereby it would be of specific value? And the second sub question is what would be the frequency of repetition in case of value being positive or value being negative?
So I think there lies the importance of study. And I would say that all those who are interested should read our paper. It's an Indian data tells you about risk stratification. If the person is willing, you should prescribe for all, and you should do it on an annual basis. That is a recommendation. If you default and a patient lands up with a heart problem, definitely they can come back and question you, and you can be said that you have defaulted on your duty of prescribing. I must also, on the record, thank Dr. Preet and the Thyrocare team, because they have probably one of the most economical anti-proBNP. I think it cost around 1,200 rupees, and
Yes.
they have tie-up with many corporates, which actually they are doing it at 500 rupees, at least the cost to corporate if they have a coupon. So I think
Yes.
that's a very good holistic thing. As a social advocacy, I must congratulate them for doing that. And they are doing it on a good Roche platform, which was the initial, I mean, which are the pioneers in anti-proBNP. So you should have a good test, because only some kits, like we use Roche kits, and that is validated. There could be some other kits which can have some QC error. That's the technical aspect of it. Madam can get better. But then comes who should be targeted. So if somebody is a smoker or tobacco chewer, if somebody has a family history of a heart disease, you can easily tell, okay, your colleague, your family member had, now start doing it 10 years before the person got it. Then if somebody has symptoms, you can always tell, I want one more investigation, please get this done. And if somebody is increasing on age and somebody with chronic kidney disease, somebody with obesity, please tell them that I have literature to support. So please get it in addition. Somebody whose BP is not coming under control, very useful parameter. Diabetic person increase in BP medication requirement, please get an antipropion.
Thank you very much for summarizing it so excellently while answering this particular question, sir. It will definitely benefit the audience. Maybe I'll ask the next question on behalf of audience to Dr. Preet. I think, ma'am, you have covered this particular point to a certain extent, but from the laboratory medicine standpoint, which were the various traditional markers which were being used to evaluate the cardiovascular risk assessment? And I think, were they specific enough? What was the feedback of the clinicians? That was the question, the audience.
Yeah. So for that, like Dr. Bhushan, I just spoke about it. There are a whole lot of cardiac markers, right, which are non-specific, but they've been used like since donkey years, right? We have lipids, we have HDL, we have triglycerides, we have their ratios. We do a whole lot of work on total cholesterol. When coming to cardiac screening, we also do apolipoproteins A, B, HSCRP. But if you look at it from point of from perspective of being sensitive or specific, none of these will give you, like I said, or they will pinpoint that yes, this is a heart failure risk, you should go for a second test of investigations, right? Now they have all of their own limitations. So for example, it can actually happen is that they have they can change via their fasting status, or they can also change because depending upon the demographics, the time of day when the test is being done, that can also impact these. For example, triglycerides, cholesterol, and all that can all depend upon what kind of a meal you've had one night before, whether you're a fasting, non-fasting, whether you have missed your statins, whether you have missed your medication. All of this will become variable. So for my clinician friends, what happens is when they look at one report, that report is probably just about okay. Now for him to say, oh, you are in a heart failure, he might not do anything, but the next time the patient would land up in a heart failure, a full-blown heart failure. Or sometimes it would happen that those parameters, all of these investigations, they are absolutely out of range, they are outliers, and the clinician would go ahead and say, oh, I think you have a cardiovascular problem, let's get you to the second set of investigations. And the moment the patient goes into the second set of cardiac investigation and shells out money, then they come back to the clinician saying, you made a wrong decision. Right? But the clinician was doing the right thing. He or she was just suspecting that the patient is developing a cardiovascular risk, or some cardiovascular problem. So there are till date also, and these are being used. They are being used. But I think it is a time for us to start propagating and time for us to start speaking about antiprobium. But that's precisely like Dr. Amaya said. We are doing all of these investigations at a very nominal cost, especially with our corporate tie-ups and our partners. This is precisely because we want to bring that awareness to the people and to understand that this is an important marker. We probably never spoke about in the yesteryears, but now is the time we start speaking. Of course, we can use these traditional markers as an adjunct, but when you have to place a finger, you have to pinpoint. This is one biomarker. Till date now, maybe in the future we would have still better biomarkers, that I cannot say for now for sure, but at least today we have this one biomarker and we should make the fullest use of it.
Thank you so much for your response, ma'am. So the next question I would like to redirect to Dr. Joshi here. And this is very interesting, sir, because you spent a lot of time for patient counseling, the counseling of T2DM patients out there. How would you see the utility of NT-proBNP as a biomarker? Because if I just put some context here from the audience perspective, when HbA1c was new in this area, so it was also very costly test, and doctors were not really inclined to prescribe that one. And later on, when it became widely available, then nowadays A1C becomes the indispensable part of entire lab testing done for T2DM patients. And this is very important from the patient counseling perspective as well. So do you see something of similar sort happening to NT-proBNP? Or if I may ask this, how would you use it for during patient counseling, the findings of NT-proBNP?
Yes. So let us start with how will I use for patient counseling. And most of the times when a diabetic patient comes to an endocrinologist, the expectation is definitely glucose control, but also prevention or identification of complications of diabetes. And many times they expect that I will be referring them to a cardiologist, and they have different reactions to that. Many times they also come with a health checkup which shows a coronary calcium scoring that is raised, and they are worried about what to do. And we all know that coronary calcium scoring is a good structural test, but we did this. We present. We Our paper has been accepted in IDF, which actually tells you that NT-proBNP is a better functional test. So if you have a normal NT-proBNP, and here the cutoff that we got was less. So if you get a NT-proBNP below 95 and your coronary calcium is little high, or coronary calcium score is still, probably you are not going to have a blockage or a significant ischemia. Whereas if your NT-proBNP is raised and your coronary calcium score is even less, you are still likely to have a significant blockage in one of the vessels. So NT-proBNP actually tells you that your heart is crying. And if you get an NT-proBNP level that is normal, you can actually tell the patient that, okay, for 1 year you don't need to go to a cardiologist. I'm doing these changes, and that's enough. So there lies the utility of NT-proBNP, or the confidence that we have. Now, how to take it ahead? And I think we are the three pillars over here to take it ahead. One is a clinician, another is a laboratory, and third are the manufacturers. As you correctly pointed out, and this is what I have been working on after our first ESD paper, which was way back in, I think, a year ago now, that I have been telling all corporates also that if you want a better cardiac health for your employees, I tell all pharma companies also that if you want that your patients or patients who are taking your medications should be benefited, you want to give them one value added test that has to be NT-proBNP, because if we increase numbers, the price is bound to come down. And obviously, the kit usage will be faster, because earlier what used to happen is, even in our hospital, you order X number of kits, a good number of that used to go unused because it was sparingly used. Now the turnover has increased, so it will become economical at all levels. The manufacturer will also be able to manufacture in bulk, which will be consumed more, and the patient ultimately, uh, all three of us, all three pillars that we are here, will benefit the fourth pillar, that is the end user.
That was absolutely right, Dr. Bhushan. I just want to add one point. Dr. Amay Joshi has absolutely, clinched what needs to be done is the need of the hour, because he actually said that even for us, when we started this, these kits would not get utilized. We also used to look at, because many people were not talking about it. Even if clinicians were talking, patients were not receptive. But more and more, if it is done, I'm sure the end user patient will be benefited. So that's an absolutely, on the point, Yeah.
Since we are talking on a very important, aspect of this entire ecosystem, patient, I think, Dr. Preet, you would agree to that the patient education, especially in the T2DM part, would perhaps be one of the most important aspect out there. And what I know for sure that Thyrocare is basically doing a lot of good work when it comes to patient education part of it. So would you like to share your thoughts on this? How do we educate the patient better when it heart care part of diabetes?
So like I already mentioned in my session, also in my talk, also the Thyrocare has recently introduced the Thyrocare Anusandhan, okay, which is a research Thyrocare research wing, and wherein what we do is we collaborate with our clinicians, right, and we look at what is exactly the next biomarker and where exactly will they want to focus on for any biomarker for that matter. We took up anti-BNP, we have taken up even prenatal markers. What we do is we do a lot of clinical correlations. We process huge number of samples. So the data in terms of values is huge with us. How to put it to use, how to clinically correlate in, for example, in a patient. For example, this parameter itself, like anti-proBNP in type 2 DM patients versus an HbA1c versus lipid versus triglycerides and all that. And where exactly will the diagnosis be clinched by our clinician friends, right? We do a whole lot of those data analysis and clinical correlation. We do a lot of publications. We do, like, this webinar is one example wherein we try to, do a lot of awareness amongst our clinicians, our franchisee partners, our, hospital partners, all of them. Most of them are now on board also. They're looking at this session also. We do a lot of those education tools. We do podcast. We do a lot of newsletter. We do a lot of leadership articles. So this is how we do basically education tools we are using along with our clinicians. So then they tell us, okay, this is my patient, this is what I'm facing as a problem. Can you help us? What will be probably the next move, they help us, give us directives. We work on the data and then we release those kind of tools. And whatever is our summaries, whatever are our discoveries, the trends we see, the patterns we see, the kind of demographics we see, and what changes, because we do these data and we see a lot of different trends also, different discoveries also, and then we go back to our clinicians, we discuss with that specialty. I mean, we are looking at this, but the research says it is discovery A, but we are absolutely looking at a different subset of points. And when we discuss and we find out that we are all in sync, only thing is there is not a common platform to do so much of discussion. That's precisely why we have started this Thyrocare Anusandhan, to have more and more education tools, not only for our clinician friends, patients, and everybody else. So that's how Thyrocare aims to spread. And of course, we'll, like Dr. Amaya said, we'll need everybody's help and support to get this going. Yeah.
I'm sure with putting all these efforts together, ultimately patient is going to get benefited in the long run.
Absolutely.
With this, I think we are 4 minutes beyond the scheduled time, and it perhaps is a good time to close this particular meeting. So I would like to take this opportunity on on behalf of Roche Diagnostics, to thank our speakers here and to thank our audience here for their patient listening. And we are quite hopeful that you got benefited from the knowledge sharing with the experts in their own arena. With this, thank you very much, and good night.
Yeah, thank you. Thank you, everyone.
Thank you, everyone.